Explain how you evaluate and manage neuropathy in patients with colorectal cancer who are receiving immune checkpoint inhibitor therapy. When you're treating a patient with colorectal cancer with immune checkpoint inhibitor therapy, you will want to make sure that you assess the patient at baseline for neuropathy. Most of these patients with colorectal cancer have been treated frontline with oxaliplatin-based therapies and are left with some degree of neuropathy. If a lot of these patients, even prior to starting immunotherapy, are already on medications for neuropathy, such as gabapentin, pregabalin, high-dose vitamin B6, so on and so forth. So again, make sure you know your patient's baseline before starting them on immunotherapy. Now, once you start your patient on immunotherapy, make sure you routinely ask your patient about any changes in neuropathy. Of course, a patient's not going to know most of the time what neuropathy means, but ask them if they're having any numbness, tingling. I have found many times that the farther a patient is out from oxaliplatin-based therapy, they may actually start to notice their neuropathy at times as those nerves are starting to regenerate. So do ask them routinely about any changes that they are having. However, if a patient is developing a new neuropathy or a significantly worsening neuropathy, it could be from the immunotherapy, and at that point you may need to intervene. Now, usually we will see if a patient will respond to gabapentin or pregabalin or vitamin B6 initially. And if they do, then it's probably not an immune event. However, if those drugs don't work, the neuropathy is worsening, it wasn't significant at baseline, and you are concerned that it is from the immunotherapy, you will want to consider using steroids in these patients. Steroid of choice is usually prednisone, but any other steroid, as long as the dosing is equivalent, would be perfectly appropriate as well. Now, one thing that I have noted in clinical practice is that the neuropathy in patients on immunotherapy does tend to be much more of a delayed side effect. The patients that we've had on single agent immunotherapy for quite some time typically develop the neuropathy. It's not one of the earlier immune events to occur. Also, keep in mind that there are several red flags for neuropathy. There have been reported cases of severe neurological issues, such as Guillain-Barré type syndromes, reported in patients with immunotherapy. So know that there can be some few, potentially debilitating, even catastrophic neurological issues to develop. So make sure you're keeping that in the back of your mind, though you probably will never see it. But ask the patient about any breathing changes, neurological deficits, or other issues that could potentially point to a more severe issue from the immune therapy. But again, those are very rare. Usually the neuropathy is just much more of an aggravating issue that bothers the patient on a day-to-day basis that can be managed with medications, including steroids. The good news for your patient is that usually the neuropathy is very manageable. However, there are going to be some cases where it's so aggravating that a patient just cannot tolerate it, or they may not do well on steroids. The steroids don't help much after a certain amount of time. And in those patients, you are going to have to weigh the risks and benefits and potentially decide whether or not it's worth continuing the immunotherapy. Some of those patients that may develop a more severe neuropathy may need to have immunotherapy discontinued permanently. Obviously, if you have a patient develops a severe life-threatening neurological issue, such as a Guillain-Barré type syndrome, those patients will need to have immunotherapy permanently discontinued.